Hello, my name is Holly Sadural, and this presentation was prepared for HAP 709 Healthcare Databases under the Masters in Health Informatics program at George Mason University. Today, I will be talking about predicting diabetes through the use of patient data. So, electronic health records and diabetes. Diabetes in the U.S. approaches about 10% of the population, which costs about $240 billion annually. The adoption of electronic health records has increased dramatically since 2009 under the Health Information Technology for Economic and Clinical Health, or the HITECH Act. HITECH Act had a goal to incentivize using EHRs and increase the quality, safety, and efficiency of providing healthcare to those who need it. In 2017, the CDC stated that 30.3 million people in the U.S. had diabetes, about 10% of the population, where 23.1 million were diagnosed and 7.2 million, or about 24% of those with diabetes, were undiagnosed. Using medical history of a patient through the EHR system is useful in detecting the possibility of diabetes. EHRs contain patient data that can be used to continuously track and monitor clinical outcomes per patient. Through simple observation, studies on how EHRs affect diabetic populations have shown improvements in diabetics' quality of life. The quality has been measured through looking at the reduced hospitalizations, improved clinical biomarkers, and most importantly, the reduced cost of care. The data that is being used for predicting diabetes is simulated data from a major healthcare institution in the United States. As you can see from the screenshot of my SQL server, I was able to import 4 different data records from the institution called DXH1, 2, 3, and 4. What I did was to combine all the records, since they had the same exact headings, into one big file. After adding the 4 data records, I had about 17 million records in total. Included in my code was to cast or to convert some of the variables into floating numbers, which will be helpful in future calculations. Now, I have used a simple piece of code to select all the data that was in the merged files. Here you can see I have about 17 million records in total. Even though we have 17 million records in total, there could be multiple entries for each patient. In this next piece of code, I was able to select a distinct ID from my combine file. So here you can see that there are 829,000 patients out of the 17 million data records, meaning that patients may have multiple records, maybe for multiple diagnoses and diagnosed at different ages. For example, I will take the first ID from my results, patient 714726, and I selected all the records that are pertain to this patient. As you can see, this patient has 8 different records with different diagnoses, all happening at the same age. There may be some patients who have multiple diagnoses, but the age at which they are diagnosed may be different. Now that I've introduced the data set I'll be using for the entire presentation, let's go into some background information on diabetes. From this infographic from the World Organization of Health, in 2016, the increasing population of citizens around the world that have diabetes is rising. Diabetes could also lead to death. According to the American Diabetes Association, there are several ways to diagnose diabetes. By getting your yearly physical that includes blood work, and your physician can determine if you have high blood glucose levels, or if you have classic symptoms of high blood glucose. However, if a patient confirms positive for high blood glucose, a doctor may require a second test to diagnose diabetes. For example, looking at your A1C levels, which measures the average blood glucose for the past 2 to 3 months. They can look at your fasting plasma glucose, where this test checks your fasting blood glucose, where you cannot eat or drink anything other than water for at least 8 hours. Another test is the oral glucose tolerance test, where this checks your blood glucose before and after you drink a sweet drink. In general, diabetes is diagnosed at a blood glucose greater or equal to 200 milligrams per deciliter. Some of the symptoms of diabetes could range from urinating often, feeling very thirsty, feeling very hungry even though you are eating, extreme fatigue, blurry vision, cuts and bruises that are slow to heal, and even weight loss. Even though you're eating, you can eat more, you may have tingling pain or numbness in the hands or feet. Now back to the data set we are currently working with. Before I am able to analyze the data, I had to clean the data for any erroneous records such as blanks, date of diagnosis surpassing date of death, getting rid of any null data, and removing duplicate data. Once my data set has been cleaned, I had to determine the ICD-9 codes for diabetes. These codes represent different diagnoses and different types of diabetes. So what I needed in the beginning of my code was that I had to take all the ICD-9 codes associated with diabetes and determine if a patient had diabetes through their corresponding ICD-9 codes. If a patient did not have any of the corresponding ICD-9 codes that relate to diabetes, I labeled them as a different diagnosis. As you can see in my screenshot, I depicted it as other DX. From that, this is my last line of code that selects all distinct ICD-9s that are not diabetes, but may predict the presence or the risk of diabetes. As you can see, there are about 10,699 other diagnoses in the current patient data from our institution. Next, I would like to show you that there are about roughly 6,000 ICD-9 codes or diagnoses that have been observed at least 29 times. What I did was to count how many times that these diagnoses show up in our data file. While looking at other diagnoses to determine if we can predict if the patient will get diabetes, another predictor could be from the gender of the patient. I had to combine another data file that had more information about the patient ID, including gender. However, this data file did not have all patients listed in the data file that we are comparing it to. Unfortunately, with the limited amount of data, I was only able to assign about 1,200 rows of data with gender. Therefore, once the predictive model is executed based off of gender, it will not be as accurate due to the limited number of data records. So from this slide, I combined the tables that determine ICD-9 codes that had diabetes in its name. This is only an example of some ICD-9 codes included in the data. As you can see from the beginning of the code, which I showed in the previous slide, these are all the ICD-9 codes that are related to diabetes. These codes are from the Clinical Classification Software CCS Diagnosis Codes website. What I did was to compare the codes on my current data, and if a patient had this ICD-9 record, I would label them as having a diagnosis of diabetes. There are some rare diseases that are not predictive from the model that I've created. These diagnoses occur more than 29 times, but less than other diagnoses. These 10 diagnoses are just an example of the various diseases that a patient may have. To fully determine how predictive these diagnoses are, we need to examine the likelihood ratio. Now that I have the associated ICD-9 codes with diabetes, from the data linked to the institution we are analyzing, I was able to determine the likelihood ratios of the likelihood of a patient who would get a diabetes with an associated diagnosis. For example, a likelihood ratio that is close to 0 means that the specific diagnosis is not associated with developing or having diabetes. In the table, I did rank the likelihood ratios. In the first line, the ICD-9 of I385.9, which is other ear and sense organ disorders have a likelihood ratio of 5. This means that there's a 5-to-1 odds that a patient were to have this specific diagnosis that will most likely develop diabetes or already had diabetes. It is important to understand that likelihood ratio just measures the impact of a diagnosis on the outcome, not imply the diagnosis will lead to diabetes. It is just a measure of association. After calculating the likelihood ratio of each diagnosis in its relation to diabetes, I use the naive Bayes theorem, which is a conditional probability. A conditional probability calculates the probability of an event condition on the occurrence of other events. It is an optimal model for revising an existing opinion, especially when new evidence or clues have been added to the data. When events, or in our case, the diagnosis, are independent from each other, the Bayes theorem calculates the probability of co-occurring probability through the product of likelihood ratios. The formula only guides the likelihood ratio of the various diagnoses to predict mortality. For example, if we want to calculate the probability of a diabetic patient having a diagnosis of leukemia, we multiply the probability of getting diabetes and the probability of getting leukemia. In our case, it would be the multiple likelihood ratios. We would multiply the likelihood ratios of getting leukemia and getting diabetes. This is an example of patient 371636 that has 5 diagnoses in their file. As you can see, this is the different diagnosis that they have, the likelihood ratio associated with these diagnoses, and you can see they are a very small number, really close to 0. That's why the odds of getting diabetes is 0 from my calculations. So pretty much this is what this is telling me, that since this patient has mood disorders, gastrointestinal disorders, even an unclassified one, Parkinson's disease, and anxiety disorders, their combination of diagnosis does not necessarily mean that they will or have diabetes. So when computing likelihood ratios, they're derived from the training set of the data. So what this means is we randomly set aside 80% of the data in order to check the validity of the predictive model. This is called cross-validation. Typically, the analysis is done 5 times, and then the reported accuracy is the average across the 5 sets. The main purpose of cross-validation is to protect against noise from the model. In our current data set, we have a lot of predictors, which are other diagnoses that are not diabetes. Therefore, the modeling noise will be large. That is why it's important to cross-validate our predictions. Once the 80% of our data, which is a training set, has been computed for likelihood ratios, we use the validation set, which is the rest of the 20% of our data, to make our conclusions. After our prediction model has been completed, we cannot stop there. We need to measure how accurate our likelihood ratios are and how accurate this model as a whole is. As you can see in the graph, we have sensitivity on the y-axis, which refers to our ability to correctly predict patients who are dead, where we have a true positive divided by the number of dead patients. And on the x-axis relates to specificity, which is our ability to correctly predict patients who are alive, which is the ratio of true negatives divided by live patients. This curve plots at different cutoff points. The area under the curve is also calculated. This estimates the accuracy of the index. An area under the curve of 1 means that there's a perfect prediction. So this model is perfect. And if it's close to 0.5, it is a random prediction. So the value of patient data. Using a predictive model can be used to screen for diabetes. A lot of clinicians still do not trust in predicting patient outcomes from diagnosis, since they believe that their day-to-day experience show that physiological markers are more predictive. For example, blood pressure, as clinicians may be more concerned with data input. They could be inputted incorrectly, which could throw off the entire prediction. However, the patient's diagnosis are highly predictive or for mortality. For example, Dr. Alemi and his colleagues examined the prognosis of patients with HIV and AIDS and found that the predictive model was a good indicator of predicting the survival of patients in 1999, where the area under the curve was 0.812, which is really close to 1, which is a perfect prediction. That is why it's imperative for electronic health records-based models are crucial. By having the past medical history of a patient and their diagnosis, it will determine their outcome if they are more likely or not likely to develop other diagnoses. In our case, it is diabetes. Without history of a patient or other patient or their diagnosis, a predictive model could have not been made. Health data is important to understand the patient and to help predict what a patient and physician needs so that patient can live a longer and healthier life. And this is my references slide that helped me make my presentation, and I hope you enjoyed my final project. Thank you.